Recording for Module 22. Before I start, let me explain a few things. So Module 22 has the introduction of the concept of addiction. 22A is alcohol abuse, 22B is nicotine use, and 22C is substance abuse. Because it's so much material, this first recording is going to be over the concept and cover exemplar A, alcohol abuse. I will stop the recording and then start a new recording on the same PowerPoint on 22B nicotine use, 22C substance abuse, and then add the small PowerPoint on the pharmacology related to addiction. Okay, so this is the concept and alcohol abuse. So what is addiction? It is defined on the beginning of the module or concept 1647, psychological or physical need for a substance or process to the extent that the individual will risk negative consequences in an attempt to meet the need. When an individual abuses any substance and is unable to stop despite danger, has a substance use disorder. That is the new terminology, and it's a coding thing, and not going to get into coding. But anyway, substance use disorder covers all of this, whether it be alcohol, a drug, prescribed or not prescribed, and nicotine, gambling, multiple things. Sorry, I mentioned gambling. That is not a substance use disorder, but it is an addiction. You can really get addicted to anything. There's substance use disorder is where they're addicted to a substance of some sort, and then a process type of disorder or addiction. Gambling is an example of that. Okay, tolerance, dependence, addiction. It is important to understand the difference. A substance-induced disorder is the actual process of becoming addicted to a substance. So addiction is a physiological process of dependence and psychological need to seek the substance, where a dependence is a physiological need for a substance that the patient cannot control, and the results in withdrawal symptoms of stop. So dependence is the physiological, addiction is physiological and psychological. Tolerance is require greater quantities of substance to achieve desired effects. There's different theories. Factors, I guess. You have your biological, genetic, psychological, sociological factors, and it's on 1648, 49, and then you get into the different theories. So Engel's biopsychosocial model. Our limbic system controls and regulates our ability to feel pleasure. When it's activated at normal levels, the system rewards natural human behaviors. Overstimulating that reward system with drugs produces euphoric effects and strongly enforces the behavior of drug use. This is psychological. So you look at here the biosocial model. You see from your text all the biological issues, all the social contributors, and then the different types, things that happen with addiction. So biological, the neurotransmitters and the reward circuit. Genetically, 40 to 60% of the population is genetically vulnerable to addiction. Psychological factors, correlation between substance abuse, childhood, and adolescent trauma. There's a link between substance abuse and psychiatric disorders. Very, very common link. Sociocultural factors, family environment, availability of drugs in the community, correlation between religion, spirituality, and lower alcohol use. And there's a correlation between the gay culture, HIV status, and substance abuse. Abuse substances and your brain receptors. This is a picture that you will see on 1649, figure 22.1, action of abuse substances at brain receptor sites. The receptor sites are either mimicked or blocked, just like everything else, every drug, pharmacological we have learned about. It's either mimicking that receptor site or blocking the receptor site. Heroin mimics the natural endorphins. So when these receptors are activated in the reward center of the brain, they stimulate the release of neurotransmitter dopamine, causing a reinforcement of drug-taking behavior. Cocaine acts by binding the dopamine transporter, blocking the removal of dopamine from the synapse. The dopamine accumulates and produces an amplified signal to the receiving neurons. This is what causes the euphoria. Different terminology that's used throughout this module: abstinence, voluntarily going without drugs or alcohol; codependence, enabling behaviors by significant others to the addicted individual. No codependence. Delirium tremors, DTs, medical emergency, 3 to 5 days following alcohol withdrawal, which we'll get into a little more. Detoxification process of safe withdrawal. Physical dependence, and there's medical detox, and then there's other like observational. There's different kinds. It does not always include giving them medications. Okay, physical dependence, withdrawal symptoms will occur if substance withdrawn. Psychological intense subjective need for a psychoactive drug. Intolerance, we've talked about before. Medical illnesses can be promoted or exacerbated by neglect of health, often seen in substance abuse and addiction. There's a higher incidence of mental health disorders with substance abuse than there is in the general population. Oh, I'm sorry. I didn't say here, if you could see, table 22.1 is on page 1651 for these terms, and I've highlighted the ones that you need to be familiar with, especially that codependence. Okay. Process disorders or addictions. Gambling, exercise, online shopping, internet, these are process, not substance abuse. They are down in the little table on the bottom of 1650. On the very bottom, be familiar with these and different treatments. And also 1653. Oh, sorry, box 22.1 on 1652, characteristics of codependent individuals. And then 1653, they start those process disorders. It all goes through 1654 because there's multiple types. Internet gambling disorders, interesting. Okay. Did I skip? Health promotion. I thought I said slide. Okay. SAMHSA, 1656, under health promotion. Substance Abuse and Mental Health Services Administration. It's an excellent site if you want information, seeking knowledge, seeking resources, anything, interested in this for nursing, go into the SAMHSA site. It's a great resource. Then there's community and local initiatives. Nurses assess patients' risk for substance abuse and provide education related to prevention. Your nursing assessment. Of course, that relationship here. Screening, brief intervention, and referral to treatment, SBIRT, to identify patients with abuse issues. This is mentioned right after the SAMHSA on the bottom of 1656. and it explains it a little bit. Okay. What else? Screening assesses the severity of substance use and appropriate level of treatment. Brief intervention focus on increased insight and awareness and motivation for behavioral change. Refer direct for extensive treatment. Men are more likely to avoid treatment due to fear of losing job, and women usually fear losing their children. Criteria for hospitalization on page 1657. Levels of care typically used in the United States range from ambulatory detoxification without extended on-site monitoring to medically managed intensive inpatient detoxification. So the criteria: concurrent mental health issues, distressing physiological symptoms, and I believe that's big with the alcoholics, increased tendon reflexes, hallucinations, temp above 100.4, and I'm not going to read this to you. Observable manifestations of addiction issues. This is on 1657. Also, unstated gait, lack of coordination, slurred speech, tremors, obvious weight gain or loss, pinpoint or dilated pupils. You can read the rest of these: lethargy or spaced out. Findings are dependent on the nature of the addiction. Be alert for symptoms that are abnormal or not within expected boundaries. Assess explanations for inconsistencies. Oops, how did I get to that slide? Okay. So, crisis assessment. Look at the questions that you need to ask on page 1657. It has observation and patient interview. There's lots of questions: individual assessment and family assessment, all the way into 1658. Community assessment, crisis assessment, stress, employment, self-harm potential, family role, lifestyle changes, possible resources, community assessment. All of those, look over those questions to be able to explain that or apply that. Diagnostic tests on 1658. Just a little paragraph there. Serum drug levels, toxicology testing, chest x-ray for inhaled substances, organ biopsies related to damage caused by substances, urine, saliva, serum testing, hair testing within 90 days. Urine toxicology is a toxicology screen. Refers to various tests that determine the type and approximate amount of legal and illegal drugs a person has taken. Note that. Independent interventions or boundary setting. Not boundary setting. Independent interventions, communication. Page 1658 also. Recovery is a state of voluntary sobriety in which a person maintains health and functions normally in society without use of addictive substance or behavior. No single intervention is enough to ensure recovery. It requires substantial work on the part of the addict. Communication. Do not talk too much. Remain calm. Listen for contingency words, signaling that the person will not follow through. Practice active listening skills, noting patient's defense mechanisms, and notice body language. It's patient-centered. Use I statements to describe concerns. Hold patient accountable. I am concerned about this. You teach the family to do this also. Contingency is, I will do this if. That's a contingency statement. Independent interventions. Setting limits is hugely important, as through so many of these mental health things. Establish parameters, desirable and acceptable behavior. Boundaries help the patient feel safe, advances therapeutic goals by eliminating non-productive behaviors. This is all setting limits, protects significant others and children from users' unacceptable behavior, teaches the person that there are choices with consequences and can be challenging for clinicians and family members. Independent interventions, boundary setting. I don't know if you guys remember Peanuts, which used to be a big thing. Anyway, I love Peanuts. So, substance abusers may frequently cross boundaries, guard against ambiguous relationships where multiple roles exist. Need to maintain those professional boundaries. Independent interventions promote nutrition. That's through everything in nursing. Collaborate with dietitian, monitor lab work, teach patient about adequate nutrition. This is 1659. Biggie for you to know. Patients who engage in substance abuse are at risk for nutritional deficiencies, alcoholism, great risk for thiamine deficiency, which is what, B6? I'm trying to remember which B vitamin. Anyway, thiamine. Monitor lab work, report significant changes to provider, collaborate with dietitian, and teach them not just about nutrition, but the physical effects of substance abuse on the body. Independent interventions to promote treatment participation. Do not accept defense mechanisms such as rationalization or projection. Keep your promises, convey acceptance, do not accept defense mechanisms. Encourage patients to examine how unhealthy coping mechanisms, maladaptive behaviors affect them and the people they care about. Note, help patients learn more healthy ways of coping, encourage participation, encourage patient participation in therapeutic group activities such as 12-step support groups, also work-related assistance, EAP, employee assistance programs. Peer feedback, often more acceptable than feedback from authority figures. That's where the having a sponsor in these groups, 12-step groups, is really helpful. 5A's, page 1960. Ask, advise, assess. Oh, what the heck is wrong with this thing? Okay. Identify and document every use, every visit, clear, strong, personalized manner, urge to quit. You do this for tobacco. You use this for everything. It's a big one on tobacco cessation, but it's used for everything. Family intervention, professional clinicians conduct intervention. Family members state how the person's addiction affects them. Do not use direct confrontation solely to force treatment. You can't force treatment. Behavior modification therapy. Page 1960. Note, patients learn techniques to modify or change addictive behaviors. There's positive and negative reinforcement. Know the difference. Positive reinforcement provides a reward for behavior. Negative reinforcement removes negative stimulus to increase behavior. Be able to distinguish those. Extinction, know this. Progressive weakening of a behavior through repeated reinforcement. Be able to apply that to a situation. Contingency contracts. Contracts are important. Note, contingency contracts, patient rewarded, contingent on meeting desired outcomes. Their effective incentives can be vouchers, cash equivalents, prize-based approaches. Note, token economies. Patients can accumulate token rewards for treatment compliance for exchange of privileges or actions. See, patient first learning behavior and rewards are given immediately. Be able to apply or identify those in a situation. Cognitive behavior therapy. Note, cognitive behavior therapy combines Behavior therapy with techniques to change their behavior. That's the behavior part of cognitive behavior. The cognitive part, scientific study of mental processes such as perception, memory, reasoning, decision-making, problem-solving. I love cognitive behavior therapy. Dialectic behavior therapy, that's something you've seen in the before with your borderline personality. There's different kinds. Okay. Milieu therapy, supportive recovery environments, pretty much what we've gone through. Provides opportunities to learn how to respond to challenging situations. The goal is to support constructive, permanent behavior change. The staff and peer feedback models constructive behavior. Accentuating informal relationships with healthcare professionals, 1961. Group therapy encourages members to remain, navigate psychological, cognitive, behavior, and spiritual dysfunctions, establish type of group appropriate for outcome. The nurse functions as a group therapist in many settings. Leader helps members relate to one another. Carries a risk of unintended adverse effects, or group members may steer conversation toward talk that glorifies substance abuse, thereby undermining the recovery goals. Oh, this is on page 1962. Also 1962, support groups. Patients define their own needs. Members have equal power. Groups may or may not be autonomous from mental health professionals. Attendance is voluntary. SMART program considers substance abuse and addiction to be complex maladaptive behavior. Yes. 12-step programs are multiple different ones. 1963. Prescribed beliefs, values, behaviors. It has a recovery stated in 12 steps. Step work is considered to be a lifelong process, usually with the aid of a sponsor. My experience, without a sponsor, they're very unsuccessful. And it doesn't mean a failure if they fall, but they get back on. Only requirement for membership is a sincere desire to change the targeted behavior. Family therapy, different types of family therapy, functional family therapy, multidimensional, addresses not only substance use problem, but other co-occurring problems, can be adapted to various settings. Positive results in adults and adolescents, addresses co-occurring problems, patient and at least one significant other. One, doesn't have to be everybody, apply strategies taught in the sessions. Pharmacological medications prevent symptoms of withdrawal. It can treat overdose. I'm not going to go into it here because I have a separate thing on that. There's different classifications that are used, and I will break those down in the next recording at the end of it. Addictions in children and adolescents. There's insufficient knowledge, limited research, hurried office visits. Not hurried office visits. Where am I? Scratch what I just said. I was thinking of the elderly. Let me go there. That's where I was. Insufficient knowledge, limited research, hurried office visits, and 1966 symptoms mimic other medical behaviors. Many older adults do not feel they need treatment and do not seek it. Sorry about going out of order, but I was on a roll. Addiction in children and adolescents. Many adolescents start drinking at a very early age. By 12th grade, more than a third have tried smoking. They have risk-taking behavior, increased risk for substance abuse. Addiction in pregnant women. Substance abuse disorder can cause neonates to experience substance dependence, withdrawal symptoms, low birth weight, neurological issues, developmental issues. I did this. Impaired nurse program, page 1666. I have helped nurses through that. Table 22, 3 on the bottom of 1666, warnings of impaired nurse in the workplace. Look over this. 10 to 20% of nurses may have concurrent or prior substance abuse issues. Most state nurses associate offer peer assistance programs. When nurses eat their young, we're not as good about supporting each other as some other associations like the AMA, but it's getting better. Some states are better than others. So different at-risk, easy access prescription drugs, role strain, depression, signs of alcohol, and signs of withdrawal. It's tough. Okay, so now we're getting into Module 22A on alcohol abuse. Alcohol includes liquor, beer, and wine. You are abusing alcohol when you drink 7 drinks per week or more than 3 drinks per occasion for women, more than 14 drinks per week or more than 4 drinks per occasion for men. That's not a bias. It has to do with our body makeup and our muscle mass versus our fat and how the alcohol affects the body. If you have more than 7 drinks per week or more than 3 drinks per occasion for men and women older than 65, again, because they've lost muscle mass and it affects them differently. It's still socially acceptable and often encouraged. The alcohol abuse in 2015 ran a cost of $235 billion in alcohol abuse pathology problems. Sold on 1668. Okay, I'm going to keep going. Pathophysiology, just what I put here, alcohol is a CNS depressant impacted by food intake, body mass, liver function. Those are things that affect the women because of the body mass, and then the elderly because of body mass, liver function. 95% of alcohol is metabolized in the liver. That's significant. And then when you combine it with other things like Xanax or alprazolam, Vicodin, which is hydrocodone, slows your heart rate and breathing and can lead to death. Risk factors for alcohol abuse, page 1670, genetics, traumatic experience, drinking at an early age, lower education, and children of alcoholic. Sociocultural, lower education, and not marrying by age 30 is a risk factor. Cultural factors such as poverty, geographic isolation, unemployment, difficulty in acculturation, social disadvantage, and alcohol availability are significant factors with abuse. And there's a dual diagnosis, dual disorder, alcohol and mental health. In genetics, the Native American have a higher rate than other populations. Their genes are associated with risk factors for drug sensitivity or tolerance, and then environment contributes to that. Children of alcoholics is another key thing. COAs, families have a higher unemployment rates also. Alcohol intoxication manifestations. I'm sorry, this thing keeps skipping. It's bottom of 1670 into 1671. I took your bullet points and broke them into short pieces here for you. Alcohol poisoning on page 1671. Alcohol poisoning is a toxic condition that results from excessive consumption of large amounts of alcohol in a very short period of time. So there's people that are grossly vomiting in the morning with this intense headache and feeling dehydrated and awful. That's actual alcohol poisoning, but it can go to the degree of leading to death. Alcoholism, consequences of chronic alcohol use, malnutrition, there's your thiamine deficiency, severe liver damage, neurobiological, psychological, other body systems such as heart disease, erosive gastritis, pancreatitis, sexual dysfunction, increased risk of breast cancer. The liver damage is alcoholic hepatitis, cirrhosis, cancer, hepatomegaly, fatty liver. Respiratory system, pneumonia, bronchitis, tuberculosis, increased risk. Central nervous system, seizures, neuropathy, sleep disturbance, alcohol, dementia, effects on reproductive, erectile dysfunction, decreased testosterone, decreased sex drive, menstrual irregularities. And alcoholism is 5 times greater risk of dementia. And there's a cross tolerance there. Alcohol withdrawal. not sure what page, I guess. Oh, alcohol withdrawal is on page 1673. Okay, the note, anorexia, visual hallucinations, and hyperthermia. This can be up 2 weeks. Hyperthermia. The biggest is 1 to 3 days, or we say 72 hours. Depends on when they had their last drink and you encounter them, how much they drink and how sick they were. So 1 to 3 days, that 48 to 72 hours is the magic number for nurses. Oh, and on your, they mentioned hypotension. I've not seen it. I've seen hypertension, so on 1673, so mark out hypotension. I disagree. Okay, Clinical Institute Withdrawal Assessment for Alcohol Revised. This is CIWA, C-I-W-A, on 1674 and 1679. This is listed. Management based on vital signs and their score. So they take their score here and their vital signs to get their treatment options or what they're going to do. Do not argue with the patient experiencing delusions or hallucinations. Talk to the patient about real events and real people. Reassure patient about being safe from harm. Factors in early drinking, 1674, 75. It's an expectation, sensitivity, and tolerance. That's like certain populations like the Indian, American Indian, and environmental aspects. Women and alcohol abuse more likely to die prematurely from cardiac-related conditions. Possible relationship between alcohol and risk of cancer, especially breast cancer. Increased dementia, Alzheimer's, memory deficit, cognitive decline, and osteoporosis. Here, alcohol-induced liver disease over a shorter time after consuming less alcohol. Alcohol and pregnancy. Most common tetragen in pregnancy, increased risk of spontaneous abortion, increased rate of prematurity, aborted placenta. Fetal alcohol syndrome is so sad. And also no alcohol during breastfeeding because it gets passed on. Alcohol abuse in the older adult, chronic alcohol use associated with irreversible tissue and organ damage. Mixing alcohol with prescription and over-counter drugs can be dangerous and deadly. You should always routinely look for substance abuse and mental disorders in all populations, including the older. Alcohol use assessment on page 1676. Oh, there's your CIWA form revised. It's a whole big thing listed on 1677, but I think I've given you enough of what you need there. So here's your assessment. Very important. How much, how often, and first use. Past alcohol, substance abuse, polysubstance abuse. Questions to elicit pattern, history of blackouts or withdrawal. Don't say, do you drink alcohol? How many beers do you have a week? How many glasses of wine do you have a week? How often do you have a drink? When you drink, how much do you drink? If you only drink on Saturdays, okay, but because you just need to have specific questions. Nursing diagnosis and outcomes. Note, participate in a support group, therapeutic group after discharge. And there are employee assistant programs if they to help. Also, usually those give like 3 visits, but sometimes you can work on that. With substance abuse and problems, sometimes there's some, if they don't have insurance to cover some, there are some Medicaid type of plans that can cover some of those things, and mental health. So it's not always not covered. Okay, patient teaching, HALT. Teach, HALT. Acronym to assist in recognizing behaviors that lead to collapse. Am I hungry? Am I angry? Am I lonely? Am I tired? Evaluate for things such as sleeping adequately. And I'm stopping here, and I will pick up on the next slide with nicotine use, take you the rest of the way through on the next recording.